get started. We've got lots of folks signing on. Okay, so welcome to our webinar on how to talk to your board of directors about changes in the healthcare system. My name is Daniela Labate. I am the Director of Managed Care Readiness Initiatives at NIAPRIS. Before we get into today's content, we're going to just do a little bit of housekeeping. So the slides from today's presentation are going to be available on MCTAC's website. It's ctacny.org. And we are offering follow-up office hours to today's webinar on Monday, November 28th from 2 to 3 p.m. So the questions that we don't get to today, we'll be sure to answer at that time. And feel free to register for that at ctacny.org. And just a reminder, the information and timelines are current as of the date of today's presentation. So what is MCTAC? MCTAC is a training, consultation, and educational resource center that offers resources to all mental health and substance use disorder providers in New York State. MCTAC's goal is to provide training and intensive support on quality improvement strategies, including business, organizational, and clinical practices to achieve the overall goal of preparing and assisting providers with the transition to Medicaid managed care. On this slide, you'll see all of the CTAC and MCTAC partners. We've got the McSilver Institute, CASA, UCSI, NIAPRIS, Families Together, ICL, and Ideas. And this slide shows you the Small Business Initiative partners. So our goal with the Small Business Initiative is to drill down a little deeper into the special challenges that are facing community providers who've got little or no experience billing Medicaid or managed care, and to assess, inform, and educate those agencies on the essentials that are necessary for managed care readiness. So as the coordinator of the Small Business Initiative project, I'd like for you to feel free to contact me directly to discuss any challenges that you're seeing or coming across, and my email address is below at the last line on this slide. And stay tuned because we're going to be planning lots of webinars and office hours and more learning collaboratives so that we can help the smaller providers really have a seat at the table. And today's training is provided by MCTAC and the Small Business Initiative partners and was developed out of a need expressed by most of you during our Small Business Initiative regional forums that just finished up a few months ago. So with that, I'd like to introduce our presenters for today's webinar, Bob Ross and Peter Beichman. Bob Ross has over 40 years of experience in the addiction services field in both private and public entities on a state, national, and international level. He's currently the CEO and president of St. Joseph's Addiction Treatment and Recovery Centers in Saranac Lake, New York. St. Joseph's provides inpatient and residential drug and alcohol treatment in a variety of settings, including 2 county jail treatment programs, veteran services, and supportive housing units. Mr. Ross has served for 6 years as the Executive Deputy Director of the New York State Division of Alcoholism and Alcohol Abuse, and for 1 year as the Acting Commissioner. He serves on a number of significant boards. He's the president of the board of the New York State Alcoholism and Substance Abuse Providers Association, president of the board of Homeward Bound Adirondacks, which is a community-based veterans support organization, and he's a board member of the North Country Community College Human Service Advisory Board. He also previously served on the New York State Governor's Advisory Council on Alcoholism and Substance Abuse Services for 5 years, and the North Country Behavioral Health Network for 6 years. Peter Beichman has worked and advocated within New York State's mental health system for more than 45 years. He spent 31 years of his career at The Bridge, a comprehensive treatment, rehabilitation, and housing agency for people with serious mental illness located in New York City. For 14 years, he served as CEO, prior to which he was Deputy Executive Director for 17 years. And before coming to The Bridge, Peter was Executive Director of the Coalition of Voluntary Mental Health Agencies, now the Coalition of Behavioral Health Agencies. And he held key mental health policy positions at the New York City Department of Mental Health and New York State Assembly. Since retiring from The Bridge, Peter's been working as a consultant with a number of organizations on behavioral health systems transformation and has been teaching and mentoring at a number of social work schools. And I can say that I've personally known Peter for over 15 years, and I've worked with him at The Bridge, and he's always managed to share information with both staff and the board in a way that was both informative, forward-thinking. He's always been positive about change and supportive of both the staff and the board. So welcome, Peter and Bob. Okay, I'd like to quickly go through today's agenda. We've already done introductions. We're going to spend some time talking about why this is such an important topic, and then we'll dive into the types of boards and how you can communicate with them. We'll touch on the goals of healthcare reform and what that means for boards of directors, and finally talk about how boards' roles are changing and offer you some strategies for how you can consider talking to your board. And we're about to jump into today's presentation, but really quickly I wanted to remind people that if they do have questions, they should use the chat box. And at the end of today's presentation, the questions that we don't have time to answer, we will be sure to hold on to, and we will answer them on the office hours webinar on the 28th. So with that, I'd like to get started. And I'm going to pass the mic over to Bob.
Welcome. Let me add my thank you to all of you who are participating, and hopefully this will be both informative and an opportunity, as has just been said, for us to go and respond to some questions that you have at the end. I think the importance of today's topic, it really comes down to two main issues. One, the fact that the world of behavioral health is changing dramatically under our feet, and that is important from the point of view of the fiduciary policy and oversight responsibilities of boards. The second point, I think, is that it's incumbent upon the boards to become much more strategic in how they do their work, and it becomes very important for management of various different agencies to figure out how their boards are currently structured to understand how they can operate in this changing environment. So I guess my initial response would be that in the 40-plus years that I've been working in the healthcare field, there's never been as much change as quickly, and therefore both management and boards have to figure out how to understand those changes and how to relate it to what's happening within their own organizations. And secondly, it becomes really important to understand for all of us who are involved in agencies from a management point of view, how the boards are expecting us to give them information. And to do that, I think it becomes really important to understand first what is actually happening in the dynamic right now between management and individual boards. I think the notion of knowing thyself becomes really important because not all boards are going to operate the same way, and not all boards are going to have the same expectations. So while there are some general points that will come out hopefully today for everyone's benefit, ultimately everybody who works with a board is going to have to try and identify how the dynamic works between management and the board in their individual agencies. Some commonalities and some individualities. So with that quick introduction, let me turn it over to Peter to talk about the self-diagnosis approach for individuals working with their boards. Peter?
Thanks, Bob. And before we get into the self-diagnosis, I just want to echo what Bob is saying about the pace of change right now. And since I have 5 or 6 more years than Bob does in the system, I can certainly say that over the past 45-plus years, we've never witnessed this amount of change in this short a time. So looking at slide 11, we have kind of borrowed from our clinical colleagues from their playbook, because we think, as Bob said, that the best place to start on the question of how to talk to the board, what to tell the board, that the best place to start is really reflecting on your current board and its style, your style as managers in working with the board. So let's look at this slide together. And first off, we know that there's a real range of the way boards operate. Some boards operate, at the 20,000-foot level. They're not so involved in day-to-day program questions. They embrace the mission of the agency, but they are less so involved than others. And there are others that are very hands-on, that are involved more directly in monitoring, developing program, monitoring program. So when you reflect on your board, the questions are, how involved are they in services and policy? It's an important question with the education job that has to be done now and the strategic thinking that has to be done now. Boards that, are more hands-on, know more about day-to-day operations, et cetera, may be in a different place in their ability to be educated and to understand the big picture than those boards that operate at 20,000 feet. And then there are questions about your style. How do you communicate with the board? Is your communication limited to the board meetings? And then how much do you share with the board? Have you shared with the board up till now? On slide 12, we get into, again, some of the specifics. Some boards have active committees beyond just the mandated committees of finance and board recruitment. Some boards have program committees. Some boards have committees that monitor quality and quality improvement activities. Does your board meet monthly? Does it meet quarterly? So that frequency question also plays into how we're going to strategize on educating the board and strategizing with the board. Do board members ever present at board meetings? And some boards, the chair of the board finance committee presents the financial picture, and in some boards where there are other committees, those board committee chairs actually present, and in many boards, board members don't present. Then who communicates with the board? Is it just the executive, the CEO, or the executive director? Do other senior managers communicate with the board, both in board meetings and outside of board meetings? And what is the communication with the board between board meetings? So what we're suggesting here overall is that in order to begin for you to strategize what and how to educate the board on all the changes that are occurring, the place to start is with your current board structure, your current board style, your style in working with the board, so that as you begin to pick some of the strategies that we're going to talk about to educate and work with the board around all these changes, that there is some continuity between the way you've been working with the board now and how you want to shape and reshape that going forward. So we know, as Bob said, that on slide 13, that there is absolute necessity at this point for an active board. There are those responsibilities that Bob enumerated of boards, certainly the fiduciary responsibility, policy responsibilities, and a significant responsibility that we didn't mention earlier is the responsibility of the board to be the keepers of the agency mission. And in this time of such drastic change and so many changes, it's very important for the board to be engaged in that effort to be reviewing the mission and addressing that. So in this time of change, also undoubtedly, new board policies are going to need to be developed. And so developing those new policies, you know, is a partnership between management and the board. And where we're going to go next in our discussion is helping your board understand the goals of healthcare reform, and Bob is going to discuss this slide.
Thanks, Peter. And actually, you gave me the perfect transition point when you were talking a minute ago about mission focus. Before I get into the specific bullets that are on the slide, as you can see in front of you, I'd like to suggest that the notion that might be helpful for us to think about from the point of view of how management and boards can best collaborate is to think about orientation. When any of us enter into a new environment or a new culture, such as moving to a new school or living in a new community, there's a blend of fear and excitement. And striking that balance, I think, is the ideal way to use the combination of opportunities, which we want to emphasize in a positive way, but also we want to be very realistic about the demands of the challenges. So I think as we discuss the specifics of what boards need to understand, the context in which they operate and which the dynamic exists between management and the boards is very important. Those of us who are in management on a full-time basis have the luxury of being able to do this more hours a day or a week or a year, but that still requires us to understand what it feels like to be in the board's position, who are doing it in a much more time-limited way and are really dependent upon us to give them information which is both useful in terms of content and also very helpful in terms of the way in which we figure out how to share that with them. So to the specifics, reducing costs, obviously one of the key parts of healthcare reform. Less reliance, on hospital emergency rooms and inpatient care, improving quality, integrating physical and behavioral health. I think a much overlooked, in historical terms, important form of communications between different silos within the healthcare field, addressing the social determinants of health, housing, food, security, access to jobs, education, lifestyle, et cetera. And I would add a couple things that are not on this list at the moment. Those of us who are familiar with the adage about real estate, it's location, 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 I would say for the healthcare reform, it's outcomes, outcomes, outcomes. We are going to have to all become more comfortable with data and analysis. I think that analytics is a word which probably most boards didn't think of in an ongoing basis, but are going to be expected to be much more comfortably conversant with that going forward. So for this list of items that you have on the slide now, and what I'm suggesting is an addition of outcomes. What we're really talking about is that the boards need to understand that these external issues, which are changing the nature of the field, become a more dominant part of their understanding of their role. It's no longer sufficient for a board to feel comfortable that it is blessed with a talented management team and a group of clinicians who can provide good quality care. Those are essential requirements, but above and beyond that, those talented managers and committed and talented clinicians have to operate in an environment which, as has been said a few times already, is dramatically changing. So the boards are no longer exclusively trying to determine how their agency is doing, but how their agency is doing in an environment which is going through very dramatic change. Switching to the next slide, the key features of the reform that the boards need to understand. Boards are going to have to be, and already are becoming, more detail-oriented. That means that they have to, as I've said a couple of times already, become more comfortable with data. They have to become more comfortable with an analytical view of how well they're doing, as opposed to what may have been sufficient in the past, which is a strong and accurate impressionistic view, and that there is knowledge of the changes of the healthcare system that have to be incorporated into their ability to absorb on an ongoing basis within a given year what's happening externally and how that impacts their individual agency. It creates a much increased responsibility on the part of executive management on how to communicate those details and to delineate for that particular board that they're working with what of the changes are most important and how those changes are happening in terms of pace and projections for the future. Specifically, managed care is a huge area that all of us are familiar with as a category, but none of us have been able to figure out all the ramifications of. So the boards are really dependent upon management to become very adroit at being able to explain in manageable terms how something like managed care is impacting their agency. Value-based payment is an even more obscure issue at the moment, but will become dominantly important in terms of the fiscal health of all of the healthcare agencies, since progressively we will be reimbursed for the value added that we provide, and that the payments are going to be dependent upon being able to demonstrate that value. So management is not going to be that far ahead of the boards as this value-based payment is developed, but yet it's going to have to be incumbent upon management to become, at each individual agency, skilled at being able to share and answer questions that the board has about managed care and value-based payments. DSRIP similarly is an available resource and a very time-consuming, for many agencies, opportunity, which each individual agency is going to have to figure out how it can best use its time and energy, connect with DSRIP to advantage their agency and the clients that they serve. Not an easy task, because similar to value-based payments and managed care, there's a lot of uncertainty about how this is working. It's dramatically different if you're talking about a big hospital versus a smaller freestanding healthcare agency. It becomes really important for the board members to progressively understand in their agency what managed care, value-based payments, and DSRIP's impacts are. The last point on this slide is there's a balance of trying to understand what's happening in the external world of healthcare reform in general and how that impacts the work and the challenges at an individual agency. There's going to be, I think, a lot of pressure and also a lot of opportunity on individuals who are involved from a management point of view in an individual agency on how that dynamic changes. And my guess is, as Peter suggested in his earlier comments in terms of the self-diagnosis, a lot of this is going to depend on what happens between the management at an individual agency and its board. So there are some generic points that are essential for all boards to do and all management teams to do for their boards. And then there's a lot of focus on how the board dynamics work, and it may be essential, it's not on the slide here, but it may be essential for management and boards to work together to bring onto boards people that have skills in analytical analysis and in data and understanding data, so that the managed care value-based payments and DSRIP can be more understandable and advance more sustainably in an individual agency. So I'm sure there are going to be some questions on that area when we go to the question and answer. So let me give it back to Peter to talk about strategies to consider. Peter?
So on this slide, we've put together some suggested strategies, and what we would welcome is your ideas and your suggestions as well to share with the group. So in terms of a strategy to first of all, educate the board on some of the key items that we've talked about, DSRIP and VBP and managed care. One of the strategies that has been used is to form small groups of board members who then can become educated on one specific topic, and then they, as a small group, can report and update the full board. So the advantage there is in terms of people's time management, et cetera, board members. If the small group can invest the time in the education piece, then they can, as kind of board experts, share with the balance of the board. One of the things we're suggesting on educating the board on some of these key elements is, use free resources. There are people in the OMH field offices, the OASIS field offices, who can come out to your agency, do a presentation to your board on some of these concepts. And, our advocacy organizations, and some of them are listed, ASAP, the New York State Council, the Mental Health Association, NIAPRIS, the Coalition in the city, they have staff who also can come out to talk about and educate boards on some of these concepts. The idea of a glossary. At the Bridge, we developed a glossary of terms. There are so many acronyms right now that get thrown around in board meetings, and so many new terms. So just having a glossary for the board members to be able to refer to and refresh themselves on what those acronyms and concepts actually mean. Using your senior management staff to do some of the educating. If you're comfortable with that, if you have staff, for example, on your finance team who are becoming expert on value-based contracting, and you're comfortable with that staff person working with the board and educating the board in that area. And we think that it's a good idea, again, to create an agenda item for the board meetings that updates the board on a regular basis on what is happening in healthcare reform and behavioral health reform at every meeting. The final bullet, I'm going to turn back to Bob to discuss. And what we've acknowledged in preparing for the webinar is that there are really two tasks involved for the board. One is educating them so that they can understand everything that is happening. The second task is taking that education that they're getting and with management then strategizing on how the agency can meet the challenges of all of these new ways of operation that are now being implemented. So Bob, you want to talk a little bit about the strategic part?
Thanks, Peter. As Peter and I were talking about preparing for today, one of the things that I think both of us felt very strongly about is that the concept and the notion of strategic planning is really shifting from just internal strategic planning, what is an agency's 5-year plan going to be, to what a term that I like particularly called strategic partnering. And that's basically looking to non-traditional partners in any given organization, board and management together, to form new alliances which will allow for strategic goals to be met using resources and collaborations across the various different silos that we all experience when we're talking about an individual agency or even an individual field. One of the conversations, for example, that has happened, I think, more and more with the field of addiction and mental health is looking for partners such as counties who have a great responsibility and a limited amount of resources. And it has not been traditional, for example, for counties and individual agencies to necessarily collaborate on strategic issues. They may collaborate on budgets for funding particular projects. But that's an example, and there are many, of a resource that boards and management can work on collaboratively. The other point, to come back to something that Peter said a minute ago, is that it's not just what you know, but how you think that I think is going to become essential for boards to become more successful. And management's ability to give the information piece, which has been discussed in some of the points on this slide earlier, but also to encourage how that information is used, which is the how you think portion. So, summary from my point of view in terms of strategies, it becomes incumbent upon management to figure out how to imagine a different set of interpersonal and interactive dynamics between management and the boards, so that the boards can, with the limited amount of energy and time that they have compared to management doing it full-time, create a stronger partnership. So again, I would summarize by saying that strategic partnering is an area that management can be very helpful to the boards in adopting as a way of approaching meeting these new challenges.
So,
good, Peter.
Yeah, I just wanted to say again, if there are folks who have used specific strategies successfully in educating the board that we haven't mentioned yet, we'd love to hear from you about how you've gone about that.
Okay, so that ends our official presentation. We're going to give folks a chance to chat in some questions, and we'll be right back with you in about a minute once we get some questions in. Thanks. So we do have one question that came in. I'll read it out for you folks. In the hopes of better understanding, I understand the move and goals to value-based payments. How does this method of payment differ from the method in which agencies such as mine and Article 31 Clinic are being reimbursed? How does the value-based method affect today's method? And I'm understanding correctly that managed care is required to reimburse agencies at that rate base for 2 years before changing to value-based.
Get here.
Bob, do you want to do that, or I can?
Why don't you take a shot, and I'll add something to it when you're done.
Okay. So, as Bob said in his remarks, well, right now, our method of reimbursement is based on delivery of a service, a fee-for-service system where we deliver a clinical service and we are reimbursed for that. What value-based payments envisions is that we will be paid not on the basis of delivering a service, but on the basis of achieving and adding value to the services that we provide. So, for example, and I think many people have been to the initial webinars on VBP. Ultimately, this is about agencies also taking risk, risk around savings for the services that are being provided. And what the system envisions is that as we move to value-based, that we will be part of a system in which we will share savings with the payers, with the managed care companies, when we achieve the savings that we think we can contribute to the reduction of costs in the system, and ultimately we'll take risk on both the upside, where we would share savings, and the downside if we don't achieve the savings that are projected. So it's a very different kind of funding from fee-for-service, which just pays us, reimburses us for providing the service. The value-based system pays us for achieving the performance goals that we specify in the arrangements that we will make with the payers.
I would just add to what Peter said the following couple of points. The biggest change will be a sense of outcomes versus being reimbursed for units of. So outcomes can include things like reduced recidivism, reduced reliance or attending emergency rooms, or what are sometimes called unnecessary or avoidable rehospitalizations. But in the broadest possible way, it seems to me that what we're really talking about is that the risk would be shared between providers and payers to try and achieve sustained, positive, improved health profiles for individuals, families, and communities. So those agencies that become more proficient and more imaginative and can document through outcomes that they are high performers in that area will become the more valued partners with the payers. And it is really a brave new world because nobody has really done this on a broad basis. There have been experimental programs in different parts of the country in different areas, but what we're really talking about is changing completely the expectation eventually, not immediately, where the provider community will be working with the payer community to try and achieve sustained improvements in health profiles for individuals, for families, and communities.
And one of the key pieces there is that the savings and performance that are looked for involve the overall amount being spent on a population. So in our world of behavioral health, we are one component of that. The other component is the medical cost side. So what the vision entails is the overall savings and efficiencies and improvements that can be achieved for the spending on both behavioral and medical. And I think it's acknowledged that on the behavioral side, you know, there may not be all that much saving, at least initially. The real savings in the system are on the medical side, as Bob talked about, emergency room, rehospitalization rates, inpatient care, so that while it's an overall picture that we're looking at, our behavioral health agencies have a key role to play in achieving these goals because we work so closely with our clients, we know them so well, and we are involved not just with their behavioral care, but also with, again, those social determinants that Bob talked about earlier. So,
I would add one more. I'm sorry, go ahead, Peter.
Yep.
I would just add one more piece that you'll hear the term more and more, population health, and with that comes one additional piece which I think is very important, and that is not only are we talking about the improved healthcare profiles, both primary care and behavioral health, but we're also talking about it over a period of time. So to the degree that an individual receives support and their individual healthcare regimen, and they contribute to a stronger, more positive healthcare profile for their family, the next generation in their family has the potential to be healthier than it might otherwise be. So longitudinally, the partnership between managed care and providers around value-based health is that some of the value-basedness of what is done has and pays dividends over time, not just over the current nuclear family. And that's going to be very challenging to measure and very difficult to include in this metric, but ultimately it will improve the quality of healthcare within communities and will save money for the payers over time. So one of the really big challenges is how do we capture that outcome and how do we reward those agencies that add that value along with the specific things that happen immediately.
So that's a typical, again, that discussion of value-based payments, you know, that's kind of an important example of something that boards really need to understand, both short-term in terms of entering into performance-based contracts that may involve risk, financial risk, and long-term in terms of the agency's ability to provide service and to partner in services that will have positive impact on the clients that we serve and reduce the social cost.
Thanks, Peter and Bob. We have some more questions, so we need to move on. This next question is about board makeup. What backgrounds and expertise do you suggest we have on our board of directors?
I had suggested a few minutes ago that one of the things of value to boards to add that might not have been on people's lists up until recently is individuals who have familiarity and expertise with data and metrics. That's necessarily something that as a part of management I would have thought about in the recent past but wouldn't fail to think about going forward, and that's an example. I think the other part of it is bringing in people who are from a more broad-based perspective than just those people who are committed to the individual services of an agency. So, for example, bringing onto a board somebody who has experience or expertise from the payer side, from the managed care, becomes a really valuable asset to have other board members and management benefit from those kinds of expertise. So those are two concrete examples that I would say represent a change from how I would have answered that question a year or two ago.
And I think that legal expertise and financial expertise will also be at a premium as the system unfolds.
Okay, thank you. Has anyone had any experience inviting a PPS to come and speak to your board?
I couldn't hear that question. Could you repeat it, please?
Well,
sure. The question was about inviting a PPS to come and speak to the board, and if you had any experience with that you could share.
I haven't had any direct experience with PPS coming to speak to a board, but I think it's a very good idea. I think, as we know, each PPS has selected its 10 or 11 projects that it's working on, and most PPSs certainly have chosen projects that in the behavioral health sphere. So I think that that it's a very good idea to reach to the PPS and invite someone to come and talk with the board overall about the PPS and specifically about the behavioral health and integrated behavioral health projects that the PPS is involved in.
I would just add to that that not only would it be useful to have the PPS talk to the board, it would be a great idea for the management to work with the board to develop a series of questions that relate to their particular agency that they would want to present and ask the PPS itself. The more dynamic that exchange, I think, the more useful.
Mm-hmm.
Okay, so our next question is about conversation and balancing conversation. How do you best balance the conversation between performance numbers and financial numbers, which both can be somewhat dense for those who don't know the service or financial aspects of the changes?
I guess my first reaction to that question is it's always terrific to have a bridge between elements of the board that don't necessarily appreciate or understand each other as well as they might. And the program and finance areas become more importantly integrated under the changes that are taking place. In the past, I think it's been possible to have a strong programmatic element within an individual agency and a reasonably sustainable, strong fiscal performance. Because of the change, the quality and speed of change that's going on right now, that may not be there, and it may be even more important for the financial of any given agency and the programmatic elements to be understood by all the board members and between the board and the and management as some historically sound programmatic activities will become much more difficult to sustain financially going forward through no fault of those, the quality of those individual program elements. The program elements may be more difficult to get paid in the same way and therefore may become under greater stress going forward. So it's a very important question on any board, and I think one that deserves a lot of time between the board and the management.
And I would echo that where traditionally there may have been, separate board committees on finance and on program, because the world we're entering and the restructuring of the financial elements that have direct bearing on the program elements. I think it is a challenge for boards to have an integrated, be able to integrate the financial and the programmatic in order to be able to really understand, first of all, and then navigate in this new world.
So I think we have time for one last question, and that question is, as we move towards value-based payment, how would you frame the discussion with the board around joining an IPA?
Well, IPAs, independent practice associations, are legal entities, and they are groups of agencies that come together to provide direct services. IPAs are governed by state law and federal law. So a group of agencies comes together to form an IPA, and they have to, well, let's talk about the goal. Ultimately, the goal of the IPA is to be able to negotiate rates and contracts with payers. In order to be able to negotiate rates and contracts with payers, IPAs have to meet certain standards that don't violate antitrust laws at the federal level. So, but in general, and OMH and OASIS are, of course, encouraging now the formation of IPAs around the state because, again, in this world of value-based payments, being a part of a group ultimately to take financial risk, being part of the group will mitigate should mitigate that risk. So IPAs are definitely something to consider. And I'll just say one other thing about an IPA. As we've discussed this healthcare system being concerned about the whole individual, the behavioral, the medical, the social determinant side, in forming IPAs, having as broad a range of services within the IPA, I think would match well to where the system is going. So an IPA that includes behavioral health services, both mental health and substance use services, that includes primary care services, that includes housing providers and vocational providers, that may even include through agreements participating hospitals. Those will be strong entities going forward in the value-based world.
I would just add to Peter's very positive and detailed explanation that the IPAs are a great example, but not the only one, of the strategic partnering that was discussed earlier a few minutes ago. And also, I think it opens up an area we haven't talked too much about today, but I think becomes part of the individual board's responsibility, and that is regional cooperation. I think that one of the things that is a part of this change in looking at how healthcare is going to be delivered and how it can be more effectively delivered is recognizing the benefits of regional cooperation among agencies, not just in one sector like mental health or addiction, but across all of healthcare, including behavior and primary care.
Yeah.
Okay, thank you, Peter and Bob. We do have a few questions that we did not get a chance to answer today, so we'll touch base and we will get back to you folks on those questions and answers on the 28th. In our office hours session. And if anyone has any other questions, please feel free to send those questions to mctac.info@nyu.edu, the address that's up on the screen right now. So it is a little bit past 1 o'clock, and I do want to really thank all of our presenters for joining us today. Thank you for all of your information, and thanks to our folks that called in and listened and asked lots of great questions. Thanks so much.